What I think Laura's getting at, and I certainly agree with it, is, and this may insult you a little bit, Alice, is don't depend on the professional patient. There are an awful lot of them around, and I find myself learning most from stopping the random man or woman in the street. I'm privileged to edit something called Clinical Crossroads that's published in JAMA about once a month, in which we take a patient who's facing an important crossroads in his or her life, back pain or cancer or mental illness, whatever it is, and we bring the patient in, we video them, we present them at a grand rounds. They often come to the grand rounds, and then we bring in a professor to discuss the issue. And we've been doing this for a long time now. We've done it 150 times, and we literally pick the patient only on the basis whether he or she happens to have that illness, because we want to study diabetes this time or back pain. We've yet to find a patient whom we put in front of the camera who doesn't have words of solid gold to bring to the meeting. We have yet to find a, quote, boring patient. We've always learned from those patients. So I would urge you to pick random people, particularly those who don't call themselves patients, and just bring them in and talk with them. You'll learn the most from them, in my experience.
I think that those are excellent comments. I just wanted to add my two cents into the fray. I think that I guess certainly from ONC's perspective, we've engaged in a great deal of transparency with regards to how we engage in our rulemaking. Certainly, participation on the standards and policy committees are great ways to pull in, I guess, perspective from the external world. But we're also trying to engage a wider population. I'm doing I guess time both within ONC and the new Innovation Center at CMS. And one of the challenges that we're facing, and really the entire administration is facing, is what is a good platform for ideation, okay? For pulling in perspective, for pulling in these wonderful ideas, okay, and really having them bubble to the top, okay, across the entire country. It's a daunting challenge, okay? We've seen platforms that are being utilized within current federal agencies, such as the TSA, such as the State Department, but also in corporate settings. Pepsi, for instance, has a wonderful platform that allows frontline employees, okay, to submit ideas, to have them voted on, to have them considered by senior leadership, those who actually have the authority to enact them. So what you'll see over the next few months are wide-scale rollouts of current initiatives that are taking place within the administration, an administration that is very much behind open innovation with citizen engagement within HHS, okay, to begin to collect these ideas. And hopefully we can learn from prototypes that currently exist across the country. If you know of any, please, look me up and, try and bend my ear on this, okay? But it is something we desperately need more of, okay? So I just wanted to make sure that was reflected, and hopefully we'll see some great ideas come to the fray later on.
Okay, well, thank you. No, I think we have time for one last question, and Holt indicated that somebody on the other side. Nancy, please.
I would like to say, number one, the panel, you're fascinating. I think you've all gotten it right. I think when you say the patients are indeed the experts and the patients are underutilized, and using the man, the woman, and the child who's in the midst of the patient experience is always correct. And I agree also that they never get it wrong. So I think one of the questions that I would have for all three of you that will serve NEHIC well and the United States well is, how do you construct meaningful opportunities for patients to participate in very significant ways, whether it is, Alice, what you are doing at National Partnership, or Will, it is what you're doing at your job with the government, or whether it's what you are doing at Harvard through the Open Notes program that you have. A second question that I have for the Open Notes program, not to be answered today, but for consideration, is, are the notes of the physician being modified as they relate to patient noncompliance based not on unwillingness to comply to protocol, but inability to comply to protocol based on insurance status and or individual ability to pay the individual out of pocket. And to what extent does that patient move past that barrier in the open notes relationship to be able to begin to approach those very candid financial discussions with the doctor that indeed will ultimately influence compliance to protocol and outcomes to treatment. And I think the project holds so much hope for everyone in America because patients view physicians still today as the primary partner they have in the journey of disease management. And to the extent we can begin to communicate with one another in an open manner, we will improve the entire system of care and compliance. So I look forward to reading the results of your study and to seeing how you're going to impact millions of patients' lives.
Can I just respond a little bit to your second question? David talked about adherence and compliance. The one thing is known about doctors is they always overestimate the amount that a patient adheres to a regimen. We're very good at taking tests. That's how we get into medical school. And we've kind of learned by now, well, if it's 60% of the time the patient takes it, I think I'm going to write down 30% on this question. And then it turns out to be 15%. I mean, we're maybe it's because we're bullish and we're optimists or because they think people actually listen to us or whatever the reasons are, but we're often wrong about that. We have begun recently to discuss this with patients, not just in the perspective that David has, but also, can you afford the medicines? You know, we have a bunch of treatment plans that I can think of. If you drive around in a Mercedes, I'm not going to worry about which medicine you take, but most people don't. And what's the reality of, I'd rather you took some pills that maybe not quite as fancy as the other pill, but if you take it, it's better than if you take nothing. And I think we're learning to have those dialogues. They're very sad, by the way. I mean, I have patients who are really depressed by virtue of not being able to do what they would like to do. It's a very sad time in healthcare in that respect. And I see people getting sicker as a result. And we should all be ashamed of it. But it's very easy to make a diagnosis. It's extremely easy to make a diagnosis. It's much harder to come up with a therapy, right? When you go to most doctors' rounds or patient rounds or sessions like this, you hear 97% of the time on the diagnosis of what's wrong and only about 3% of the time on the therapy of what should you do for that patient. And you're urging us to think about that side of it, and I think you're right to do that. It's very hard to come up with the right answers. There's some medicines that really work and that are really expensive, even for really good reasons. And that's a conundrum that our society hasn't really addressed, and it won't be easy to address it.
I thank you for your question because, of course, it's the question, at least for us, of here's this vision that we've put forward, and then how do we make it a reality? And that's why I have a job. So I don't quite know the exact steps to do that right this second, but I will say that stage 2 of meaningful use, the first draft of measures which were put forward last week, includes a criteria related to use of a patient portal, or PHR. I can't believe what the precise terminology is in the draft criteria, but it's this idea that we have to start somewhere, and one of the ways that we have to do is by getting doctors and patients to communicate with each other through patient-facing tools. And this stage of meaningful use would hold providers accountable for getting their patients to log into or download or use in some way. And again, my lawyer hat, when I read this, I said, what does use mean? But we'll get there, to use this patient portal. And like I said, I think so much of this is a culture shift and an attitudinal shift and increasing responsibility on the part of patients and increasing trust in patients' information and patients as a resource on the part of providers. So as we were saying earlier, meaningful use is necessary but not sufficient, but hopefully it's one of the first steps in involving patients, and if this becomes something that is, in phase 3, it would be a higher percentage of patients that are using it, and then patients don't really have a choice but to become participants in their care, at least through the portal. And our hope is that spurns increased engagement in a broader variety of ways down the road.
Alice, the one comment I'd like to share, certainly this will not be new information to you, but in regions of the country where we still do not have consistent access to the web and to internet, our public libraries and our Social Security offices are playing very strong roles in providing consumer access to the same information so that they can become engaged at the same way. So
yes,
to the extent we can include that in our processes moving forward, I think it begins to serve all of the people in America.
Absolutely.
Thank you.
In the Harbor View component of our experiment, half of the patients don't own their own computers. And they go to that magnificent library in the middle of Seattle, or they go to a little room that Harbor View has set up for patients to use computers. Of course, everyone in Seattle knows how to use a computer better than anyone in this room. It's true, actually. We've had focus groups with people who spent their lives going through windows they shouldn't go through and doing all kinds of things. But boy, do they know how to use computers. So it's a little bit of a strange place for that. But it comes back to the point that, and anyway, everyone's going to have a computer soon. In case you haven't noticed, everyone has a color television set. And when they came out, no one was ever going to have a television set except for the rich, right? It changes very quickly.
Well, I think the time is very close to 3 o'clock, so I think we need to conclude today's stakeholder forum. Like Nancy, I think you used the term fascinating, and I actually agree. I think I would second that one. This has been a very interesting panel, which I think we will think hard about as we proceed on with our work over the next year. Should we give them a round of applause? Yeah. Now, we obviously look forward to continuing the conversation as well as working with you as we try to move forward with both health information exchange, state level, nationally, as we sort of begin to move into the future. I guess given that it is now 3 o'clock, hearing no objection, we will adjourn this meeting. And that next meeting of the board is on February 17th. So thank you.